Thank you very much, Katerina. So we're now going to move on to hear from, beside me here is Arsen Thorosyan, who is the Minister of Health from Armenia. Thank you for joining us. Now, I want to hear from you about the fact that the economic and professional incentives tend to drive increasing specialisation of health workforce, and it's happening really worldwide. At the same time, there's a lack of valuing or devaluing the occupations, the competencies that go with primary health care and responding to the health needs of the population. Armenia is currently facing this challenge. Could you describe the steps that you are taking or considering to remedy this, as well as some of the key obstacles that you are facing?
Thank you. Let me answer your question a bit broader to introduce what we have now in primary care in Armenia, so that everyone understands what we face now. Ladies and gentlemen, almost 40 years passed from the Alma-Ata Declaration, which is recognized as the major revolution of the 20th century in the field of healthcare. Particularly, it identified primary healthcare as the key to the attainment of the goal for health for all. And let me account the progress we've made in the recent years. It is known that before the collapse of the Soviet Union, Armenia had one of the most developed and dynamically growing healthcare systems in the USSR, which has covered all population free of charge healthcare services. But the independent Armenia was not able to maintain the bulky and the not very effective former system. And in mid-90s, with the active support of the international partners, the government of Armenia started healthcare reform program with the special focus on strengthening of the primary healthcare. Armenia was one of the first countries among the Commonwealth of Independent States to establish chairs of family medicine at the Yerevan State Medical University and National Institute of Health and Basic Medical College in 1997. As a result of that, nearly all of the primary care physicians and nurses working in primary care facilities were retrained, and now country has about 85% of coverage with the family nurses and doctors in primary care facilities. We have set up the program to encourage redistribution of specialists from capital Yerevan, which is the biggest city, to the regions by providing the reimbursement of residency training for students who will commit to work in regions after the completion of specialization, including family medicine. During these years, lots of rural facilities were renovated, and now we can say that more than 600,000 people in rural areas are covered by primary care services free of charge, starting from 2006. So, since the Alma-Ata Declaration, the world has changed dramatically. But one thing has not changed: the healthcare. Primary health care in particular is provided by people and for the people. This is our ideology, which we are committed to enforce by implementing further reforms in primary health care. Our key reform in line with Sustainable Development Goal 3 will lead to achievement of universal health coverage, assurance of accessible, high-quality, effective and prevention-oriented primary health care. We will increase the total health budget, including the budget for primary health care. It is envisaged that the PHC state budget allocation will be increased by 27% compared with this year. Special attention will be paid to substantial increase of development, training and retention of the healthcare workforce, especially for primary healthcare. We are dedicated to bring present-day technologies in primary healthcare, including electronic health and telemedicine. We also prioritize the introduction and implementation of health workforce register to have comprehensive data on health workforce distribution and other characteristics across the country. Rethinking of present-day incentives could be one of the options to increase proactivity and address population health challenges. Accordingly, starting from 2010, in Armenian performance-based financing model of PHC has been implemented, which allows workers to receive additional financing in case of reaching specific indicators, targets, and which will improve prevention and early detection of the most common NCDs, decrease unnecessary hospitalization rate, and increase number of quality of contacts between PHC providers and patients. And I can tell you that we have increased PHC per year visits from 2,000.1 in 2000 and 4.1 in 2017, so nearly 2 times. And one general key obstacle that we are facing in primary healthcare services appropriate to future needs will have to be able to deliver effective management of chronic diseases. We need to develop a broader approach to PHC that encompasses the broad range of health services that can be provided efficiently at community level outside the walls of hospitals. The PHC strategy needs to focus on more than just the core team of family doctors. PHC must be accessible, equitable, quality, comprehensive, people-centered, efficient, acceptable, available, so many characteristics. And will be delivered across the whole life, from birth to the death. Dear colleagues, in conclusion, I would like to say that all of us are here to create a future of healthcare. I'm sure that our common efforts based on the principles of equity and human rights will make lives of our citizens safer, healthier, and happier. Thank you.